Well, welcome to the next episode of the Beauty and the Beast podcast. I'm Sam Jejurikar, a plastic surgeon in Dallas, Texas, and as always, I'm joined by my co-host, Dr. Salvatore Pacella, who is in both San Diego and La Jolla, California, and a renowned international expert in eyelid reconstruction. And so, luckily, today, what we are talking about is eyelid surgery. Eyelid surgery, to most patients, Sal, would you agree, represents something that they think is a really small operation? You know, like, oh, I'm just going to get my bleph done. I'm going to just get this little bit of skin taken off my upper or my lower eyelid. And they view it as being sort of an inconsequential operation. Is that an accurate way to look at the eyelid?
I would have to describe eyelid surgery as small but mighty, okay? And I think, when you're talking about the upper lids for most surgeons and most patients, I think are pretty straightforward, okay? I think the philosophy is understanding aging around the periorbital region, around the eye, and that includes the eyebrow, it includes the upper eyelid skin and the lower eyelids. But I think where the finesse comes in, where there's the potential for a lot of problems, is in lower lid surgery. So, Sam, you do a lot of eyelid surgery. Tell me a little bit about your philosophy of upper eyelid rejuvenation.
Upper eyelid rejuvenation is one of my favorite operations to do. It's an operation that I think is relatively straightforward and one of the few aesthetic operations that I feel as though I can do as good of a job with the patient being under local anesthesia as being under general anesthesia. You had mentioned understanding the brow aesthetics. And I think one of the things that patients have to understand is that sometimes what they attribute as being a heavy upper eyelid may actually be some droopiness of the brow. And that could be due to gravitational factors. That could be due to heavy Botox. But it's important for people to understand that when you get hooding that extends beyond the eyelid itself, when you get out here, oftentimes that's the brow that's contributing to it. And so my general philosophy is that less is more when it comes. I've seen plastic surgeons be overly zealous in the amount of upper eyelid skin they can take out, and then patients can't close their eyes afterwards, and you can have problems with dry eyes. So my thought is we want to take out a conservative amount of skin, enough where the patient, looks like they're rejuvenated. If they've got bulging fat pads in the upper eyelid, we take that out.
So let's talk about fat for a second. So one of the philosophies you and I always talk about, and it's very popular in the aesthetic surgery world, is volume and fat. Okay. How does that play in the upper eyelid? Because when I was a resident or a fellow, I saw a lot of surgeons taking out a ton of fat from the upper eyelid. What are your thoughts on that?
I think we've gained an appreciation in plastic surgery that being conservative with fat removal pretty much everywhere in the body, with a few exceptions, ultimately preserves a more youthful appearance to patients. So if someone has a very profound bulge in the inner portion of their upper eyelid, I will conservatively take some out. But if it's not visible, I feel as though if we take it out, we can make them look hollow and actually make them look older.
Yeah, and I agree. It's it's that outside, the lateral aspect of the eye right here. I think that can be problematic if you over resect it. And so a lot of times in my upper eyelid procedures, I'm adding additional fat into just the outside of the brow or the lateral brow,
Yep.
or even deep into what we call the A-frame, which is just above the pupil. That prevents what we call a deep sulcus or a hollowed out appearance.
And yeah, and it really illustrates how we've grown over time to understand how the aging brow is not about its position as much as it's due to volume loss. When we trained, really popular operations that were done frequently with the same frequency as facelifts were hairline brow lifts or coronal brow lifts, where you would just pull the brow up and make patients look really artificial and fake looking. Now, I think there's an understanding is when you look at models, when you look at people that have a youthful appearance to their eyes, they're losing volume, and adding fat like you're describing can make a big difference. But let's talk about the lower eyelids, Sal, because in the world of plastic surgery, lower eyelids are sometimes considered to be a no man's land. And I've watched you on many panels talking about lower eyelids, and talking about some of the really complicated reconstructions that you've done. So when we talk about some of the revision lower eyelid surgeries that you do and that you've presented in many national meetings that I've seen, what are the most common problems you see, and how can plastic surgeons prevent them from happening?
So that's a great question. I will say that the lower eyelid, any lower eyelid surgery can be fraught with problems. And I think the best medicine is prevention, right? And so to me, that involves really doing an appropriate physical exam before the patient and really understanding your strategy of lower eyelid rejuvenation. For example, when I'm sitting in a consultation with patients and we're looking at their lower eyelids, I will probably sit for a good 30 seconds looking back and forth at each eye, ask them to blink about 100 times. And then you have to reach out and touch the patient. You have to understand how their tissue is. And you'd be surprised, patients who look like their lower eyelids are reasonably tight at the corner, what we call the canthus, have a lot of laxity. And that's, to me, that's the single biggest error in lower eyelid surgery that I see patients come in for, is the corner of the eye. We need to understand when we're evaluating a patient for lower eyelid surgery how prominent their eyes are. If their eyes are very prominent, it means that many times when you tighten up the corner of the eye, the lower eyelid has a tendency to clothesline underneath. And that's a devastating complication that we call ectropion. Very difficult to fix, and we're going to spend some time talking about that. Well, Samir, let me ask you a question. So what is your main approach to lower eyelid surgery? Do you routinely do canthal fixation?
So I think, one of the things that I've come to recognize both through my aesthetic fellowship, but mainly by talking to you over the years, is the importance of what plastic surgeons call the middle lamella, or which is the middle layer of the lower eyelid, which is basically the muscle layer. If you can avoid scarring in that plane, you are going to have a better positioning of the eyelid postoperatively. So if I do find that a patient has bulging eyelids and I need to take out some fat, I'll do it from an approach from the inside of the eyelid, which we call a transconjunctival approach. If they need skin removal, I'll be very conservative in the amount of skin that I'm going to take off. If you take out too much, you can cause the lower eyelid to drag down. So I'll do what's called a pinch, where I'll take out just a tiny bit of skin, or I'll even just do a laser. But then canthal fixation, coming back to suspending the eyelid, is very important. And there's basically 3 ways to do it. The first 2 ways I do, and the third way I refer to you. So, the first is a basic thing called a canthopexy. A canthopexy is where I'll typically do it through the upper eyelid. You take the little tendinous portion of the outer eyelid and you just fixate it to the inner portion of the orbit, and that's usually adequate for the majority of my patients. For more severe cases, I learned from Richard Listman, who was an oculoplastic surgeon in New York City, who was someone I spent some time with during my fellowship, how to do what's called a lateral tarsal strip canthoplasty, where you basically shorten the eyelid and you can tighten it. But for really severe cases, where there's a profound, just inadequate amount of skin or profound scarring, they need a much more complicated operation. And I think this is a perfect thing for you to describe, because I've never done the operation.
Well, let me ask you a question first. So before we dive into some of these bad complications, common question I have from patients is, when you tighten up the corner of my eye, I like how my eyes look. Is it going to change the shape? Am I going to look Asian? How do you answer that question?
Did you start singing that song by the Vapors at that point? All right. The simple answer is no. I think particularly with a canthopexy, the analogy I'll use to them is if you have, a shower rod and a shower curtain, you're basically just pulling it a little bit tighter on that same rod, and they should maintain the same shape that they have. It's a little bit more challenging with a lateral tarsal strip that I described, which is why it's usually reserved for people who have just profound, looseness or laxity of the eyelid. And that one, I still feel as though I can maintain their shape pretty close to what it is, but there is some potential in shape change for the eyelid, which in some patients, that's what they're looking for. Some patients, the converse of that is for patients that want to have a shape change, that's a pretty powerful operation for doing that.
Yeah, and I think one of the exciting things about plastic surgery is, compared to, say, building a house or construction, right? If you're a carpenter, you got to understand height, width, and depth, X, Y, and Z. As a plastic surgeon, we have to understand all 3 of those, but there's another dimension, time, right? And so we have to account for dropping of tissue. We have to account for gravity. We have to account for swelling. And that's, I think, where our experience comes in. So this is a good segue to talk about some eyelid disasters. So, so I'm going to show a short video here. So this is one of the more common operations I do. I hate to say it's common, but it is common in my practice. These are patients who have significant issues with their lower eyelids.
And just to be clear, 99 out of 100 plastic surgeons don't do this operation. Like, this is a very uncommon thing for,
Thank you. That's very complimentary of you.
Yeah, this is a
1 in 1,000. Here we go.
Yeah.
So this is an operation where where patients who qualify for this operation, the laxity of their lower eyelid, what we call the tarsal ligamentous sling, is essentially beyond repair. So what we're doing in this operation is we're replacing that entire system. So in this video, you can see we're taking a little tendon from the wrist and we're placing that in the medial corner, the inside of the eyelid, and we're rebuilding the entire strip of the bottom, the cartilage of the eye. And from there, what we're going to do is we're going to suspend that to the upper portion of the eyelid. And to me, this is a beautiful operation. It takes a little bit of time to do, but I want to show you these befores and afters here. So this is a woman who's had about 3 or 4 blepharoplasties in the past. She's got a bunch of stuff going on with her upper eyelid, so we did this all together. And then we're really suspending that lower eyelid using this palmaris longus technique. And you can see from the bottom here, she's got beautiful blinking and beautiful eyelid closure, and there's a great canthal tilt, the corner of the eye.
beautiful.
And, unfortunately, not an operation for the faint of heart.
Yeah. That is an absolutely beautiful reconstruction of a very complicated problem. And what I don't think most people watching this podcast probably recognize is how hard of a problem that is to fix when you have that degree amount of lower eyelid malposition. The other thing I want to touch on, because it's a common thing that many patients that have undergone a blepharoplasty is something called chemosis. What is chemosis? How common is it? Is it something patients should worry about after a blepharoplasty?
So chemosis is a very common issue after lower eyelid surgery. What it is imagine the white of the eye, what we call the sclera. You're looking at somebody's eye, the triangle, the white triangle on either side. Okay. So after surgery, what can happen is the muscles of the eyelid are very weak. They don't want to close exactly right. Okay. And so when that happens, that can cause desiccation or dryness of the white of the eye, the sclera. That is going to create a bubbling appearance to the eyelid. And it's an exceptionally annoying thing for patients and annoying for surgeons alike, okay? And what that's caused from is the drying of the eye. So the key for that is hydrating the eye and stopping the cycle of eyelid exposure, of eye exposure. And so commonly what I do to prevent that is again, the best medicine is prevention, right? We want to choose the right operation for each patient. Second thing I do is on the day of surgery, I oftentimes place a temporary stitch in the corner of the eye, what we call a frost suture or a tarsorrhaphy suture. Mm-hmm. That's a suture that obstructs the vision about a third of the way through. Patients are still able to see vision centrally, but we put this little stitch at the corner of the eye for the first week, and then we take it out, and that prevents the eyelid from opening up excessively and preventing more problems. The third thing we can do with chemosis there are various drops, such as ocular decongestants or steroids that we can give for patients. And I think, once chemosis gets beyond a few weeks, it can be even more problematic. I don't want to show a video of what we do for that afterwards.
I've seen a video of what you do for that, and I've had to do that in a couple of patients.
Yeah.
Makes a big difference when you do it, for sure. And that's basically just tell them what you're doing, though. What do you have to do in that situation?
So in those scenarios, again, we have to stop we have to put an interruption in that eyelid opening, right? Mm-hmm. So we have to oftentimes cut that little segment out and then close the eye temporarily again. So again, not for the faint of heart.
Yeah. Right, Sal, upper eyelids, lower eyelids, complex eyelid reconstruction, all of them have different recovery times associated with them. What do you tell your patients about what you can expect from a recovery standpoint?
That's a great question. And I would say that the lower you go in the face, the more recovery, right? Mm-hmm. So in general, I think when we're talking about brow suspension, brow lifts, it's a pretty easy recovery, I would say. Sutures are in for about 7 to 10 days, a little bit of swelling. You don't look really abnormal. The upper eyelid, there's no easier procedure to recover from, I think, when you're talking about it. Yeah. You have some sutures in for about 7 days, very minimal swelling. It's not uncommon for patients to go back to work at 7 days and really look like they have had nothing done. One little cheater I give for my patients, there's a reason I have these glasses on here, these big kind of Wayfarer glasses. So I oftentimes tell patients, if you're worried about it, going back to work or going on Zoom, just get some big chunky glasses and you can, this hides it pretty well. Patients won't focus on your eyes afterwards. The lower eyelids, much different story. I think you have to multiply that sometimes by 2 to 3x, particularly in the case if you're doing upper eyelid surgery at the same time. All of that swelling wants to go downwards. The lower eyelid holds on to a tremendous amount of swelling. So whereas upper eyelid surgery may be 1 to 2 weeks, sometimes lower eyelid surgery lasts 4 to 6 weeks for the swelling. And I think that's something patients really got to be prepared for.
And what's the role of ice, over-the-counter supplements? Is there any role for that in speeding up the recovery in your mind?
So let's first talk about over-the-counter supplements. So a lot of patients use arnica. To be honest with you, I haven't found a really effective arnica product out there. I just don't know if it does all that much. Ice is critical, I think, for patients. However, if you're using fat in the eyelid, I try to avoid ice, okay, because we don't want to damage or kill those cells afterwards. But ice is really the best postoperative treatment for patients.
Yeah, I agree with those things. I do find that arnica might speed up, the resolution of darker bruising a day or two. I find bromelain is helpful for bluish, greenish, yellowish, more yellowish and greenish bruises. Pineapple extract, bromelain. And then lately, and it wasn't so much me driving this, I've had a slew of patients getting hyperbaric oxygen therapy. And hyperbaric oxygen is interesting. I think there's something about that higher pressure environment that may be forcing some of the swelling out. And they do look better faster as well.
One of the things I want to touch on in addition to recovery is vision changes, okay? So not uncommonly, patients can experience transient vision changes, particularly in lower eyelid surgery. If you think about it, the cornea, the eyeball is connected. It's like the elbow bone's connected to the arm bone, right? So it's all connected. So you have swelling of the lower eyelid, you're going to have swelling of the cornea, you're going to have swelling of the sclera. That can transiently cause some eyelid problems. Not eyelid problems, but changes in vision. Patients oftentimes will find that their glasses are not their reading glasses, they need a stronger prescription or they need a stronger distance prescription, and that's transiently. So I think that's important to prepare patients for.
When should a patient get worried about it? Like how long is too long for them to have visual changes?
It can sometimes visual changes can last upwards of 6 months. So I wouldn't be spending a ton of money on getting new glasses until about 6 months if you need it.
Well, good. Well, and I think if there's any take-home messages from this episode, it's that viewers need to realize that eyelid surgery is one of the most common things that we do in plastic surgery. It is the gateway to looking youthful, but there are things that can go wrong. And it's important that you recognize that if there are complications, there are still things we can do about it. All right. Well, thanks for watching the Beauty and the Beast podcast.